Awesome. Good evening, everybody. Thanks, Adam, for that all too kind introduction. I hope everyone is doing well tonight, and it's my pleasure to be here. Nate Lighthizer, faculty member and dean at the Oklahoma College of Optometry in Tahlequah, Oklahoma. Yeah, it's hard to believe that we have had OCTA in our practice it's been right at a decade now. It was either late 2015 or early 2016 that we got OCTA. That's just shocking to believe that it's been a decade already with OCTA. And, we continue to learn more and more and more about OCTA. How do we utilize it? One example that, again, I'm not going to talk about tonight, but is in, central serous chorioretinopathy. I was reading an article recently, and, we think of central serous chorioretinopathy as this benign condition, and you do an OCT and you educate them, you observe, and you're all good. And then come to realize that we now know that it's about 10 to 25% of those cases have a choroidal neovascular membrane, especially in the recurrent cases. So it's now our standard that we do an OCT and an OCT angiography in our central serous chorioretinopathy patients. We continue to learn and evolve with this technology, which is just wonderful for the practice, but most importantly, wonderful for our patients as well. So this is Advancing Retina and Glaucoma Detection and Management with OCTA. If you've been to my lectures before, you know I like to poll the audience. This is a fun thing to do. You don't have to do this, but grab your phone and scan that QR code. Scan that QR code, and when you scan that QR code, that will open up my Poll Everywhere page. And when that opens up, you don't have to download anything. You don't have to sign up for anything. If it asks you to sign up for something, just hit skip for now. Skip for now, but scan that QR code with your phone or anything that's connected to the internet. And again, I'm going to ask you a couple of questions right at the start here. Let's gauge, how many of you have OCTs in your office? How many of you have OCTA? I think it's always interesting. So again, scan the QR code. It's completely anonymous. Nobody will know what you put. I won't even know what you put, but just a nice way to poll the audience in an anonymous fashion. Again, you don't have to download anything. You don't have to sign up for anything. Hit skip for now if it asks you to do that. But again, just a fun way to poll the audience there. So again, I always have a couple of intro questions. Do you have an OCT in your office? Again, if you missed the QR code, it's still in the top right corner. It's been fun to see this evolve over the course of the last 10 to 15 years as I've been lecturing on OCT technology, whereas this used to be like 50%, 40%. Now, when I ask this question, the answer is routinely between 75 and 90%. Let's see what you guys think. There you go. 88% of you have an OCT in your practice. The vast majority of docs, again, this is almost always between 80 and 90%. Here's just as an interesting question, all right? Do you have OCT angiography in your practice? Yes, I do, or no, I do not. So 88, 89% of you have OCT in your practice. Again, same kind of answer here, or same kind of question, but now it's for OCT angiography. And, I think, well, it's interesting, as Adam said, like OCT 25 years ago, where maybe 20% of docs or 30% of docs had it in their practice, okay? We're 50-50 now, okay? 52-48, and this is certainly an OCTA lecture, so we're probably gonna have more docs that have OCT angiography. They're interested in this topic. When I ask this question at a state association with 150 docs in the audience, it's usually about 20 to 25% of docs have OCTA in their practice, and about 75 to 80% do not. So, but the stats are going up, which is amazing. And you guys know there is now a code for OCT angiography starting in 2025 that pairs with the 92132, 92133, and 92134. We have an OCT angiography code, which is 92137, OCT angiography of the retina. You can see the payment there, about $57 for that. Again, you're familiar with the other OCT code. So, we now have a code, long overdue. We have a code for OCT angiography, and I love the fact that I think that's gonna drive more people to get OCT angiography, and they will realize all of the benefits that we have with OCTA. So, this is the next chapter in posterior segment imaging. Again, it's 11 years in the making now. Our OCT has evolved from time domain to spectral domain, and OCT angiography has evolved as well. Images the retinal microvasculature without a dye injection, and we can then see things that we can't see otherwise. We can't see those choroidal neovascular membranes with the naked eye oftentimes. We can't see capillary dropout, enlargement of the foveolae vascular zone. To be able to see things like that is just so beneficial for our patients. We'll talk about all those benefits here in just a little bit. How does this work? This works via en-face imaging. Slice, 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 slice through the retina from the very superficial retina, and it goes deeper and deeper and deeper. And we'll get into that more in just a second. But it also uses motion contrast to detect flow. There's multiple scans, multiple sequential B scans, and the only thing that should be moving is red blood cells within the vasculature. So when you take multiple different scans, the difference between those two B scans is the only things that are moving, which is red blood cells, and that is motion contrast. So flow, blood flow. Flow is the difference in between sequential B scans, and that's how it images that. Here's the en-face imaging that I was talking about. Again, slice, 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 slice. Again, we're looking at motion contrast, but we're starting at different layers of the retina from the very superficial layer, the superficial plexus. Notice internal limiting membrane to inner plexiform layer. Then we go to the deeper plexus, internuclear layer to outer plexiform layer. Then we go to the outer retina. Then we go to the choriocapillaris there. So just different slices through the retina, that en-face imaging. And this is not new. You can do en-face imaging on your OCT. This is a quick case. I'm not going to spend much time on it at all. Unexplained decreased vision. Patient sent in from a retina specialist trying to figure out why we're 20/60 in this right eye. You take a look at this right eye OCT on the left side here, and that's not a 20/60 retina. Yeah, we've got a mild epiretinal membrane, but if you told me that patient was 20/20, I wouldn't argue with you. Certainly they should be 20/30 or better, but yet this patient is 20/60, trying to figure out why. Again, mild epiretinal membranes, right eye and left eye, again, looks pretty good. But when you image this in a different way, we were talking about right before this went live, it's so fun, the Visionics folks, their Solix OCT, which I've been using since 2019, just a phenomenal device. It has features that we uncover all the time. Go, man, I didn't know it did this. Yeah, it's awesome. This is one of those features that en-face imaging, slice, 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 slice. And this is not OCT angiography, but you can do this for your regular OCT, and it looks at the internal limiting membrane, and look at how much better it images this epiretinal membrane compared to this picture right here. You can get just an idea of the extent of this ERM and the vastness of this ERM, and well, maybe is responsible for this patient's symptoms. So remember en-face imaging. En-face imaging, that's those different slices through the different layers of the retina there. So, and we're going to go through this in just a second. OCT angiography. You can't know what abnormal is until you know what normal is. You got to know what normal is first. So what is normal? Again, back 8-9 years ago, looking at OCT of the retina, and you take a look at this, and this is a very, very normal OCT angiography image of a healthy optometry student. And notice this beautiful superficial capillary plexus, the deep capillary plexus, the outer retina, which is largely avascular, and then the choriocapillaris. Very, very normal. Notice there's no numbers on here. It's not quantifying the size of the foveolae vascular zone. It's not giving me the density in different areas of the capillary network. This is what we started with 10 years ago. And again, it's a beautiful image. We just, wow, look at those capillary networks, both superficial and deep. But it was beautiful. It was a qualitative image, and we had no numbers, okay? And then you could blow up each image, or the superficial capillary network and the deep capillary network and the outer retina, which is largely avascular, and then the choriocapillaris as well. So again, beautiful images, perfectly normal. This is exactly what it should look like. But again, this was 8, 9, 10 years ago, before we had analytics. Give me some numbers. You guys want numbers on your OCT. You don't just want that B scan. When you're scanning the optic nerve in glaucoma, give me my overall retinal nerve fiber layer thickness and the quadrant analysis and the segment, the sector analysis. Give me numbers. And while this image is great, give me numbers and analytics. And that's what Optovue, now Visionix, has done so very, very well. So, we're going to go through a few conditions. Let's start with maybe one of the flashiest ways to use OCT angiography before we get to glaucoma, and that's macular degeneration. You take a look again, we've been using this for close to a decade now, and here's a 71-year-old Native American female referred in, for this left eye, this pesky left eye, 20/70. And isn't this ultimately our job in retina? Am I going to refer this, or am I going to hold on to this? Has this going south and I need to send it on to a retina specialist, or am I going to observe this? I'm going to watch this. I'm going to monitor this. I'm going to educate, and I'm going to follow this patient closely. It's risk assessment. Unlike anterior segment stuff, dry eye, red eyes, swollen lids, we treat ourselves. When it comes to a lot of retina, it's like, am I just going to monitor and observe and educate, or it's time to punt this out the door? Am I going to refer this, or am I going to watch this? So again, that's a lot of our job in macular degeneration, diabetic retinopathy. Again, 20/70 in this left eye, 20/70 in the left eye, Amsler grid defect. There's the back of both eyes. Again, we're 20/20 in the right. We are 20/70 in the left eye in this particular patient. All right, OCT. You take a look at the OCT in this case. OCT in the left. OCT in the left. Here's my question for you. Again, I'm going to poll the audience about 4 of these quick cases. Concerned, slightly concerned, or not concerned in this. Again, polling is open. Encourage you. Again, it's completely anonymous. Nobody's going to know what you put. I won't even know what you put. Go back to the 71-year-old female. She's 20/70. There's the back of the 2 eyes. 20/70 in the left eye, 20/20 in the right eye. OCT, OCT, and again, OCT. Again, I'll get you the OCT angiogram in just a second. I want to know, are you concerned, slightly concerned, or not concerned in this 71-year-old female? We're leaning towards, yeah, I'm kind of concerned, slightly concerned. Most of you have some degree level of concern. So, let's add in. I wouldn't fault anybody that said, Nate, I don't know if I'd even need OCT angiography on this one. I take a look at that OCT and look at those outer retinal changes. We got a little bit of subretinal fluid there. I'm Amsler grid changes, vision is down. Yeah, I'd probably pull the trigger on referring this one even without the OCTA, and I wouldn't argue with you on that one. This one's pretty darn obvious, but the beauty is when you add in the OCTA, and this is the right eye, the 20/20 eye. There's nothing here. This is normal. Very, very, very normal. When you add in the left eye, there's the left eye. And take a look at this beautiful image of this choroidal neovascular membrane right in this area. To be able to see that, to find that, to show the patient we are growing abnormal blood vessels here and we need to get this taken care of. That's a powerful image for the doctor and for the patient as well. So again, you may have said, Nate, I knew there was a CNVM even without that. Yeah, you're correct. But boy, it's nice to be able to image this and image it one step sooner than we could before. And I'll drive that home here in a couple of cases here. So again, there's that one. Here's another one. Referred in for OCT change due to vision changes. We're 20/20 in the right eye and 20/40 in the left eye. All right, coming in for OCT. We've got some vision changes in the left eye. Again, 20/40 minus. There's the back of the right eye. And the back of the left eye. Back of the right eye, back of the left eye. Remember, we're 20/20 in the right, 20/40 in the left. All right. OCT, 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 OCTs, and regular OCT. So unlike the last case that was a little concerning in one eye in the last case, we've got a couple of OCTs here in a 20/20 right eye, 20/40 left eye patient. Looks not bad at all. But here's my question for you. Once again, concerned, slightly concerned, or not concerned at all? And again, I'm not leading you on this one, just based on what you're seeing here. based on this information, again, the OCT, the photos, 20/20 in the right, 20/40 in the left. What do we think? Last one, about 2/3 were concerned and about a third slightly concerned. You know, this one, it's kind of like, yeah, we're kind of right down the middle. You guys are perfectly evenly split there. Perfect even split there we were for a second. You know, it's never wrong to get more data, more testing. Knowledge is power. So OCT angiography in the right eye. And again, we're taking a look here at this outer retina and macular degeneration. Again, diabetes and diabetic retinopathy and retinal vascular disease, I'm looking at these two on the left. This one here, I'm looking at for this in the choriocapillaris, and we are imaging an atypical membrane in the right eye and maybe the early starts of an atypical membrane in the left eye here. This is raising a red flag. My concern level went up just a little bit. And to me, this is the beauty of OCTA. To image this before we're leaking fluid, before we have intraretinal fluid, before we have subretinal fluid, makes it very, very nice to have that. So again, I'm more concerned. Maybe I don't send this to Retina. Maybe I just follow more closely. I educate better. You know, I see the patient more often. I do additional testing, things like that. Maybe I pull the trigger on an earlier referral because of this information. Here's another one, 71-year-old female, again, referred in for OCT for glaucoma and AMD, 20/40 right eye, 20/30 left eye, was 20/20 minus on the referring exam. There's the back of the right eye. The back of the left eye, again, we're 20/30 to 20/40. OCT. OCT of the right. OCT of the right and the left. Okay, I'm just taking a look at these OCTs in different ways here. Okay, different ways. Back to the photos. Let's open up the polling here so you guys. Okay, this case, concerned or not concerned? Same question. Am I concerned? Am I slightly concerned? Or you know what? Not concerned at all. Let's see what you guys are thinking here. Come on, question, open up. There we go. Polling, there they come in. All right, OCT. Again, OCTs, go back to the fundus photos. Fundus photo left eye, fundus photo right eye. Vision's 20/30 to 20/40. I don't see any major intraretinal fluid there, but you know, let's take a look. What do you guys think? And again, we got 6% not concerned, 24% slightly concerned, 71% concerned. Again, to be able to image this, you know, I was a little concerned with this area here, outer retina. Is that the development of a choroidal neovascular membrane? And we absolutely can say yes, 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 yes in this patient here. When you take a look at that outer retina and see this, again, beautiful image of the outer retina in this particular case here. So yes, absolutely, to be able to image the outer retina for the detection of abnormal blood vessels, that is significant and that is key. You know, I show you 3 cases in a row where it was net, you know, 3 choroidal neovascular membranes. Way more often than that, it's this. You know, we've got a patient with macular degeneration, it looks dry, and you do an OCT angiography and you see this and all looks good. I'm not really seeing any developments of any abnormal blood vessels here. Again, no subretinal fluid, no intraretinal fluid, and the OCT angiography is not picking up any abnormal vasculature. So this gives me the confidence, one extra layer of evidence that I can hold on to this in this particular case here. So more often than not, it comes back normal like this, and we have no presence of choroidal neovascular membranes. I'm going to skip through, just for time purposes, on to our next category of disease here. So we covered macular degeneration. Okay, looking at that outer retina, that choriocapillaris, for the development of vessels that should not be there. You don't want a CNVM there. You're looking for the presence of abnormal blood vessels. So how about glaucoma? You know, and we're still learning about OCTA in glaucoma, having images that look like this, that we can image that peripapillary vasculature, the vessel density as it occurs around the optic nerve. We all know that 35, 40 years ago, we didn't measure retinal nerve fiber layer. We waited until there was a visual field defect, and now we can detect it sooner with retinal nerve fiber layer loss. But now we can look at the vessel density, and I still believe it's a chicken or egg argument. Does the vessel density go first, and then that leads to RNFL, or is it RNFL and vessel density? It's hard to say, but if you made me pick, I'm starting to believe more and more that it's the vessel density that goes first. Those peripapillary that vessel density around the optic nerve there, and to be able to image that now is so very valuable. And we're going to show you some printouts that look like this, that allow you to image the optic nerve and have your retinal nerve fiber layer readings. Again, the hemi analysis and the quadrant analysis, and you've got all the printouts that you're used to, but it's also got vessel density in there as well. And we're still learning on this. We are still learning what this should be and what this shouldn't be. Let me show you a case here. 61-year-old male. And this patient was sent in to me by one of the what I'll call the big dogs at Cherokee Nation. Our partners said, can you take a look at my father and take a look at him and take good care of him? He's a glaucoma patient, but doesn't really take his medications. He was diagnosed with glaucoma in 2016, started on a drop, had an SLT, and then it had no care from 2017 to 2021. You go, that's just not what I want to see. I saw this patient in August of 2021 for the first time. 2025, both eyes. There's the pressure. I'm like, all right, that's not terrible, not bad for the pressures. I actually was pleasantly surprised when we had no care for 4+ years that the pressure is still hovering where it should be. I'm kind of saying under my breath, thank you OCT, or not OCT, thank you SLT that held the pressure probably in that range, because we're not still taking our drops, okay? Grade 1 nuclear sclerotic cataracts. There's the back of the right eye. There's the back of the right eye again. And you go, all right. Significant cupping of that right nerve. There's the back of the left eye and a centered view of the back of the left eye. And again, both eyes together there. And you go, whew, we certainly have significant asymmetry. Gonioscopy has to be done in this particular case, although I will tell you it was non-contributory. There's the visual fields. Give you a couple of seconds to digest these visual fields. Obviously, we have a significant visual field defect in the right eye, outside normal limits, defects within 5 degrees of fixation. This is a picture of a severe visual field defect in the right eye, and again, borderline in the left eye. But again, I wasn't overly concerned with the nerve in the left eye. The good news is here's a visual field from 2017. So at least we haven't seen rapid progression in the last 2-3 years. That's good news for potentially the long term of this patient. It has remained relatively stable from February of 17 through September of 2021. So again, I think we say thank you SLT in this particular case. Here's our OCT. Again, OCT, and you take a look again, matches the asymmetry of the nerve appearance, matches the asymmetry of the visual field defect. I mean, you can see the significant asymmetry in retinal nerve fiber layer, right eye compared to the left eye, ganglion cell analysis, right eye compared to the left eye. Frankly, will look fairly normal in the left eye with significant damage, significant thinning and changes in that right eye. Let's add in the OCT angiogram. When you add in the OCT angiogram, again, get used to your scans. Get used to your scans, and you take a look at this right eye and left eye, and we're seeing, what we saw with our previous version of the Optovue Avante OCT here. Now we have the Visionix, the Solix, and it gives you these just beautiful printouts. We've got the retinal nerve fiber layer thickness. Okay, we got that. And if we checked this box here, and understand your device and all the features, why aren't there colors in this retinal nerve fiber layer plot? Because we haven't checked that box here. If we had checked this box, then we'd have colors here. So if you're ever wondering, maybe the box got unchecked accidentally, why are there not colors here? Check that reference database box, and that will add the colors here, okay? But notice the numbers are significantly different in the right eye compared to the left eye. Significant thinning, right eye more so than the left eye. But again, you knew that from the previous version of the Avante here. Now we have the Solix. and we're imaging those vessels around the optic nerve. I mean, you can clearly see it follows the nerve fiber layer pattern. It follows this pattern, and we've got our RPC vessel density down here, and you take a look at this. Look at the difference between the right eye and the left eye. It matches the asymmetry that we saw with visual fields and with the optic nerve appearance and with the regular OCT. So, you know, we're seeing this, how this correlates so very, very nicely. I would encourage you guys, as you're looking at your glaucoma patients, your glaucoma suspects, you're already getting this scan. You're already getting the retinal nerve fiber layer. You're already getting the ganglion cell analysis. Again, here's your ganglion cell analysis in here as well. This is your one-stop shop printout. You got fundus photos, RNFL, ganglion cell analysis, and go ahead and do that OCT angiography of the nerve. And I think you're going to start learning more and more and more about how well this correlates between RNFL, just like we have learned that RNFL correlates with visual field defects as patients progress in glaucoma. So, you know, do these scans. Your optic nerve head, your RNFL analysis is in the top box. Your optic nerve and head analysis is in the middle box or the second box. There's your ganglion cell analysis. And lastly is your vessel density around the nerve, superior, inferior, average, and for the entire image. Again, it's not hard to qualitatively and quantitatively see the difference in those vessel densities, both superior, inferior, on the average, and for the entire image as well. So yes, you can do the printout. If you didn't have that, this is what your printout's going to look like. Okay, here it looks like without the OCT angiography image in it. You might as well add it in so you can have that extra piece of data in these glaucoma patients. And if you start to see changes in that vessel density over time, we watch glaucoma for so many things over time: progression, 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 whether it's visual field, OCT, ganglion cell, IOP, or OCT angiography. Get that scan over the nerve and watch those numbers over time. Watch those numbers over time. And if you're seeing changes, that's going to tip me towards we need to intervene in this patient. Or if we've already intervened, we need to add some therapy, repeat therapy, lower their pressure more than it already is. So again, and obviously this patient was actually diabetic as well, and we can get OCT angiograms of the retina, of the macula as well. And we're going to go into this in just a little bit, of getting those FAZ measurements, those capillary network measurements. You still get all your regular fovea stuff. Look down bottom right, retinal thickness. You've got the retinal thickness. You've got all of that area here. But now we've got FAZ measurements, we've got perimeter measurements, we've got vessel density maps, so we can follow this patient over time. There's different ways that you can look at this. I'll show you one of the other ways that I like to look at it here in just a little bit. Again, cornea map in this patient, take photos. It's the beauty of this Solix OCT. You've got a fundus camera in there, you've got anterior segment stuff, topography and tomography now with this OCT. So I'm skipping through this because, again, for time purposes, we've only got about 9 minutes left, and I want to get into the diabetic stuff as well here. So I encourage you to start looking more and more and using your OCT angiography in your glaucoma patients. You're going to learn a lot. And again, we are still learning. OCT, we're pretty well versed. OCT angiography, we're learning more and more. We're a decade in. We've used it more in retina than we have in glaucoma. We're maybe in the with OCT, we're a middle-aged adult now. We've had it for a while. It's not been around for 70 years. We're not elderly at this point and like 95 years old. But OCT, it's kind of its middle life. It's been around for quite some time. It's mature. OCT angiography, we're kind of a teenager. We're kind of a teenager with OCT angiography. It's been around for 10 years now, maybe a little longer. But for retina, it's been around, again, teenager. For AMD, for diabetes, glaucoma, OCT angiography, that still stays in its first decade of life. It's of your kids. It's an 8-year-old. It's not a newborn. We know a decent amount about it, but we're still going to grow a lot. We're still going to learn a lot with OCT angiography. Get this piece of data. Their chin is already in there and their forehead up against the forehead rest. Go ahead and get those OCTs and get the OCT angiography as well there. Okay, I'm skipping through this because I want to move on to another condition. We talked about glaucoma. Let's talk on diabetes in our last 7 minutes here, okay? This is very important. You know, I would encourage you guys to scan your diabetic patients. We are seeing more and more and more diabetes, and we take pictures, and it's awesome. You can do that with your Solix, that device that so many of you know very, very well. You know, take pictures, but this is not imaging the capillary networks. This is not imaging the foveal avascular zone. You are not getting that information, and especially as you start to see diabetic retinopathy, okay, we need to get this information there. Remember, the macula can go both ways. It doesn't just go that way. It doesn't just swell. It can be ischemic as well. It can be thin. You can get diabetic macular ischemia, which is a predictor of diabetic retinopathy progression, can be tied to vision loss. So don't just do your OCT to pick up thickening. Do your OCT angiography of the macula to look for ischemia, to look for signs that, you know what, things are not going well in the eye here. Obviously, way less invasive than OCT, or excuse me, than fluorescein angiogram, okay? What does this do? This detects enlargement of the FAZ, the foveal avascular zone, and there is literature as far back as 1984 that show abnormalities of the foveal avascular zone in diabetic retinopathy, the FAZ enlargement of this. And again, got ramped up in the 2010s as OCT angiography came about, of enlargement of the FAZ, enlargement of the FAZ. When you see changes in that FAZ, as it gets bigger, again, your FAZ should not be getting bigger. That's a sign of capillary dropout. As you're seeing that, that's a sign of changes and maybe the earliest signs of diabetic retinopathy. So I expect the FAZ somewhere between 0.15 and 0.25. 0.15 and 0.25. I'll show you some printouts in just a second. And if it's getting bigger than that, watch this over time. Just like we watch RNFL in our glaucoma patients. And if you see this increasing over time, it's a poor prognostic indicator for that patient. You know, you look for capillary non-perfusion, assessment of capillary dropout in the superficial and deep capillary plexus. You know, this is what the vessel should look like. This is what the vessel should look like. And if you start to see things like this, notice the enlargement of the foveal avascular zone, irregularity of the foveal avascular zone, capillary dropout, capillary irregularity in both the superficial and the deep capillary plexus. Again, there's no numbers here. That's how it was 8, 9, 10 years ago. Now we have numbers, as we'll talk about in just a second. Boom, there it is, your FAZs, your FAZ measurements from 0.17 to 0.24 to 0.305. You know, as those are getting bigger, that's a bad sign. That is progression of diabetic retinopathy. We have trend analysis. You know, you look at this over time. Your device does so many different things. You can watch. This looks just like an OCT printout for glaucoma, whether it's ganglion cell or RNFL, letting us know, you know, is the FAZ area getting bigger? Is the perimeter getting bigger? You've got the numbers here. Watch this over time, hopefully for stability or for progression, in which case we need to educate better, follow them more closely, may recommend nutritional supplements, etc., etc. Okay? All right, so again, I want to go through this quickly because I want to get to a couple of cases at the end here. Again, ideal for managing patients here. Okay, so can't know what normal is until you can't know what abnormal is until you know what normal is. We've covered this already. OCT, very, very normal, looks great. Notice the difference in the FAZ between normal and abnormal. Once again, normal and abnormal. Now the image, the B scan is bigger because notice the auto zoom button is clicked here. Normal, once again, and abnormal. FAZ is bigger, it's a little bit more irregular. We've got some capillary dropout again, and we haven't even added the numbers in yet, which we're going to do here in just a few seconds here. So let's add in, you know, it's great to have a perfect picture, a great picture, but we've got to have numbers. We've got to have that those vessel densities. So let's look at these angiolytics. You know, from Optovue, now Visionics. You know what normal is. We've covered this already. Let's add some numbers, okay? Flow or non-flow. Flow in areas that shouldn't be there. This is choroidal neovascular membranes. Clinical applications, again, choroidal neovascular membranes. The development of abnormal vessels that should not be there. Abnormal blood vessels that should not be there. Again, I'm looking at the outer retina and the choriocapillaris. Are they developing flow that should not be there? There's a CNVM. Or non-flow. Capillary dropout. Now we have blood not flowing as you have capillary dropouts. This is your diabetic retinopathy, your artery and vein occlusions, other vasculopathy. Again, looking at FAZ measurements, as we've talked about already. Clinically, I consider normal between a 0.15 and a 2.5. And again, there's your FAZ measurement, 0.315. That is abnormal in our clinic. That is abnormal in our clinic, the FAZ of 0.315. Vessel density maps, okay, but ultimately at the end of the day, let me show you the actual print. I love this printout, okay? Gives you the qualitative data at the top. You got your slice, 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 slice. Again, AMD, I'm looking over here. AMD, I'm looking over here. The superficial capillary network, the deep capillary network, okay? And bottom left is where I really look, the OCT angiography, so we can see these numbers. And again, there's lots of different ways that you can do this. You can slice it in so many different ways. Your FAZ measurements, measuring your FAZ. Now we've got it in different kind of quadrants or areas that you can look at that vessel density, giving you numbers. And we already looked at this in our patient. And you can see all of this on one printout, from the retinal thickness to the FAZ measurements, to the deep vessel densities, to the superficial vessel densities, and then we've got our maps here as well. So again, following this over time. I'm going to finish in my last 5 minutes. 3 quick cases. 54-year-old Native American female. She's a pre-diabetic. Okay, pre-diabetic, not diabetic, but strong family history. Strong family history. Thinks she's probably going to develop diabetes pretty soon. I'm like, why do you think that? Because everybody else in my family developed diabetes. Got some systemic symptoms that make me concerned. But she's pre-diabetic at this point. She's 2025. Anterior segment's unremarkable. There's the back of the right eye and the back of the left eye. Okay, back of the right eye, back of the left eye. We're pre-diabetic. Back of the right eye, back of the left eye. OCT. OCT angiogram. And OCT angiogram here. You take a look, and again, that bottom left plot in this type of printout, I love to look at that, and I'm looking for, I hope my capillary networks are in the greens and yellows and oranges, kind of thick, nice thick. As you get capillary dropout and this falls into the blues, that is loss of capillary density. That is the loss of that capillary network. So I'm a little bit concerned that I'm seeing this already in a pre-diabetic patient. We didn't talk about ERGs tonight, but this patient had an abnormal handheld ERG as well, which, just like OCT angiography, it can be a sign of progression, sign of things that are not going well in this patient. So we had a reliable and unreliable and abnormal ERG. Because of that, and because of the OCT angiography, I went, I just don't quite like how this looks. Strong family history, some systemic symptoms that make me concerned, and the A1C was 8.4. I said this patient for lab work. Is this patient pre-diabetic? No, this patient isn't pre-diabetic. They are a diabetic patient, A1C of 8.4. My question for you is this. When you didn't have this data, this patient was just diagnosed with diabetes here and here. That's what their OCT looks like. When would you see this patient back? And you would have answered, and I would have answered, a year. And because of the OCT angiography and the ERG, when you look at this OCTA, because of that, this patient is much more likely to progress. This patient needs to be seen in maybe 4 to 6 months. Another opportunity to educate this patient and let them know that you are fairly young and you're already showing some signs of abnormalities in the eye. So remember case number 2. Case number 3, 48-year-old Caucasian male in for his annual diabetic exam. No complaints, no concerns. He thinks he's doing well. He thinks he's doing well. Type 2 diabetic for 16 years, and he's fairly well controlled at 6.6. 20/20 in both eyes. Back of the right eye. Back of the left eye. OCT of the right. OCT of the left. Yeah, looks pretty good. OCT of the right and the left look pretty good. Back of the eyes look pretty good. We're 20/20, A1C 6.6. And hey, look at the OCT angiography in the right eye. And note that plush capillary network right eye and the left eye matched it as well. Color vision was normal. ERG was normal. All functional testing all looks good as well. So which case would you be more concerned about? Case number 2 or case number 3? The pre-diabetic or the 16-year diabetic? Generally speaking, it would be the 16-year diabetic, but yet the ERG was way better in the 16-year diabetic, and the OCT angiography was way better in the 16-year diabetic. So I'd be more concerned with the newly diagnosed diabetic. Last one, 77-year-old male, type 2 diabetic for 19 years, last A1C 8.9. He's frustrated with his vision in the left eye. I can't see as well in the left eye anymore. There's the back of the right eye. couple of small MAs. Couple of small MAs here and there in a 77-year-old male, 20/20 minus in the right, 20/30 in the left, OCT of the right, OCT of the left. It looks pretty good. OCT angiogram. You take a look at the OCT angiograms in both eyes here. Okay, and the reason I did these 3 cases in a row are the newly diagnosed diabetic, case number 2, the 16-year diabetic, case number 3, and the 19-year diabetic. You can see the difference, and guess what? ERG matched as well. ERG, and I have seen that, your ERG matches your OCT angiography. These capillaries are so very important to be able to image these and see these, and then to see the functional. They go hand in hand. Your OCT and OCTA and your ERG, they look at completely different things, structure and function, and there's nothing else that we have minus a fluorescein that gives us the beautiful pictures of this. To be able to show, and I encourage you, take a picture. When you guys get OCTA in your practice, you already have it, you should have a laminated photo of every printout, your OCT of the macula, your OCT of the optic nerve, your retinal nerve fiber layer, your OCT angiography, your favorite printout of the macula, OCTA, and your favorite printout of the optic nerve as well, of normals. Your technician, maybe it's you, whatever, of a very, 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 very normal. And so you can show them, this is normal. In this case, it'd be the middle image. This is normal, and this is what we're seeing here. We're seeing some of your blood vessels that are not there anymore, that are dying out. We're seeing some capillary dropout, Mrs. Jones, and this is very concerning to me with your diabetes and specifically your diabetic retinopathy. And we need to watch you more closely and maybe perform some other testing and communicate with your doctor and lower your A1C and maybe consider nutritional supplements. There's a lot. Don't think that there's nothing that you're going to change. You absolutely should change something if you see an OCT angiogram like the one on the left or the one on the right compared to the normal in the middle. If you had a terrible angiogram of your heart, your doctor is going to be having some serious conversations with you, following you closely, sending you to a specialist, maybe putting you on a medication. Shoot, you might have a stent or something else done. Lots of things can be done when we get this information with OCT angiogram. So, again, I encourage you guys to look at this over time. Your FAZ measurements in your diabetics, those vessel densities, looking at them over time as we've done. We have trend reports that look at this over time. So lots of avenues to use OCT angiography. We went through these very, very quickly. I have reached about 45 minutes. So Adam, I'm going to pause here for questions.
All right. Well, thank you so much, Nate, for that broad overview. And again, if anybody has any questions, feel free to type them in the question box for Nate, and we can sort of review all of it. So I'll take the questions in the order in which they are given. So a question here, I guess this is a coding question. So starting off with practice management. So
Yep.
again, so you mentioned before right at the beginning that OCTA now has a code. That's a relatively recent development. I guess it happened just in the beginning of the year.
Yep.
But this person was asking, in a diabetic patient with no visualized retinopathy, can you still do an OCTA and bill for it?
So my understanding currently, we are not doing that. If you have a 2020 patient with no diabetic retinopathy, again, if somebody knows otherwise, correct me if I'm wrong, but I've been told that you cannot. However, if they have an abnormality on the OCTA, maybe it's an enlargement of the FAZ, maybe it's capillary dropout, you now have an abnormal OCTA, and I would consider that patient has now some degree of retinopathy based on my clinical opinion, and you bill that from there on out. So I've been told that if they're perfect, no hemorrhages, no retinopathy, perfect vision, well controlled, you might struggle getting paid on the 92137, but if they have any vision changes, any vasculopathy, any retinopathy, anything at all, abnormal functional testing, then you can.
Great. Question here, more, I guess, about the nuts and bolts of a scan itself. I don't think you were able to too much get into it, but the question is, this person says they were familiar with the older technology, I guess when this was, brand new, that's got to be over a decade ago. The scan acquisition time, can you speak to that at all with the more modern units?
Yeah, the scan acquisition time has just gotten quicker and quicker and quicker to be, and the software is just so much better to be able to, remove artifacts and, different things that you can get as you're scanning there. We used to have to take a scan with OCTA in one direction, like horizontally, and then you'd have to take it vertically. Now it does it all in one scan with a little mini blink in the middle. So acquisition speed has increased tremendously. If they have small pupils and they have significant lenticular opacities and they have SBK everywhere, you're going to struggle just like a regular OCT is. And there's a variety of different tricks that you can do to get the best scan possible. But yeah, acquisition speed has not been an issue at all. If your patient can sit there and get an OCT, they should be able to get an OCTA as well.
Right. Question here, I don't quite understand this one, but maybe you can make sense of it for me. Did you say that for diabetes and vascular conditions, you're looking at the two images on the left, angiosuperficial and angiodeep?
Correct. Yeah. For retinopathy, I'm going to try to get a printout here so you can see, when you're looking at this, and actually I'm going to go quicker through this so we can get back to when I'm looking at those en face images in retinopathy. Okay. When you're looking at retinopathy, you want to look at the two images on the left. Okay. I'm looking at the superficial capillary plexus and the deep capillary plexus. And then when you're looking at AMD, you are looking at the two images on the right, which is the outer retina. And come on here, we'll just do this one. These two, there's the superficial capillary plexus. Look at all those retinal vessels, those retinal capillaries. This is what diabetes affects, is the retinal vasculature. So I'm looking at these two on the left. Am I developing non-flow? What is non-flow? Enlargement of the fovea vascular zone and capillary dropout. There's a lot of flow in these capillaries in this very, very normal two scans on the left. This is a normal optometry student, and there's a lot of flow there, okay? So I'm looking for in retinal vasculature, diabetes, diabetic retinopathy, vein occlusions, artery occlusions, things like that. I'm looking at the two on the left. When we look at our outer retinal conditions, like the development of choroidal neovascular membranes and macular degeneration, histoplasmosis, pathologic myopia, things like that, we're looking for the development of abnormal flow. A choroidal neovascular membrane shouldn't be there. Obviously, it's a choroidal neovascular membrane. It's got blood in it, so it's abnormal flow. So outer retinal conditions, AMD, I'm looking at the two on the right, and retinopathies like diabetes, I'm looking at the two on the left. But again, this is the scan from 8-9 years ago. You still look at it this way, but look at those analytics as well. But yes, that's how we look at those.
Right. Interesting question here. So I guess to preface this, I'll just say, before this sort of non-invasive technology, most of us were not sitting around all day looking at angiograms, right? This is not something that you do routinely. But now, with this technology, you can actually start looking at angiograms every day in your office, using OCTA. The question is, for folks who actually have never done any interpretation before, how hard is it to actually get up to speed with this? And how did you actually do it to learn to do the interpretation?
Well, it's been a slow process for us because we've had this for a decade. And again, we started with, like I said before, we started with images that just looked like this. This is exactly how I did it. And I just learned going, okay, this is a nice looking image, and I had to kind of eyeball it 10 years ago, 8 years ago. Okay, and that's where the numbers, the analytics, the angioanalytics, and Visionics has been the world leader in this, to take you from printouts that look like this, which were beautiful. Okay, and again, I looked at just kind of qualitatively, ballpark, how does the vessel density look on this one? I skipped through this case, but you guys, everybody look at those two scans on the left. That's a beautiful superficial capillary network and deep capillary network. And if we go back here to cases that I skipped over, here is a long-standing 30-year diabetic. How do those two scans look on the left? They look horrible. They look absolutely, that capillary network looks nothing like this. Looks nothing like, so that's how I learned, was just doing a lot of cases and seeing this and having to go, all right, that's certainly very normal. And it's very, very abnormal in a 30, 40-year diabetic, and in between is cases that look like this. And you go, okay, the FAZ looks bigger, it looks a little remodeled, looks a little atypical. It looks like we maybe have some capillary dropout in this area, but it completely changed when we have numbers. When you go to the analytics, like I'm, going back to here, and you start to have printouts that look like this. And look like this, and you have FAZ measurements, and you can follow them over time, like I showed you guys, after we went through these cases. So how do you learn over time? Number one, you learn by doing. You learn by just doing this, and you learn that the things that I looked for were, just like I said, those images that I just showed you guys, like back here, like there, like this. It started with just the 4 on the top. And then we have this plot down here, which is great, because then we at least had some colors here and some changes. And if it got into the blue, that means we got some capillary dropout. And then we could measure, the FAZ like this and the capillary networks. And so that's how it's evolved over time. And that's how I've learned over time. Start with, I look at the 2 on the left for diabetes and retinopathy, and the 2 on the right. And again, you're going to learn very, very quickly and pick this up very, very quickly.
Right. Question here, I'm not even sure you can answer this, maybe some of the folks at Visionics can. How were those quantitative analytics actually derived, right? So you're seeing things with red and blue and green and so forth. How did they actually figure that out, to determine abnormal versus normal?
I will let the Visionics folks chime in after I answer, in case they need to correct me. Back in 2019, we were one of 5 sites for the reference database study. We had to scan 115 patients, some of them in their 20s, 30s, 40s, 50s, 60s, 70s, and 80s. We have a lot of normals. Again, this is the reference data, or the normal database, the reference database. Well, as an optometry school, we have a tremendous amount of normals, especially in their 20s, 30s, 40s, with all the faculty, staff, students, loved ones, etc. So me and one of my colleagues, we scanned about 115 subjects in 2019, all normals. You can't see me, but air quote, all normals, because it was the normative database or reference database. There was 5 sites, and we had to do all these scans on normals. How did we know they were normal? We did an eye exam on them. They had no pathology, no retinopathy, and we did all these OCT angiogram scans, and that establishes your reference database, your age-matched reference database. That was in 2019. And then the FDA requires repeatability and reusability studies. Repeatability and reproducibility, repeatability and reproducibility. So in 2021, post-COVID, we had to recruit 150 subjects that had AMD, diabetic retinopathy, both proliferative and non-proliferative, like I said, AMD, dry and wet, and all these different retinal conditions, glaucoma conditions, some normals, and we had to scan them with 3 different Avantes and with 3 different Solixes, with 3 different operators. They went from my room where I scanned them with an Avante and a Solix to another doctor's room where they scanned them with a different Avante and a different Solix to a third doctor's room where they got scanned again with a different Avante and a different Solix to make sure that these measurements are reproducible and they are repeatable. So I learned a ton during that, going, holy smokes, the hoops that these companies have to jump through to make sure the data that you get is an age-matched reference database and it's reproducible and repeatable.
Wow. So for the person who asked the question, they got it from the horse's mouth, the person who actually generated the data.
If the Visionics folks want to chime in and add anything or correct me, but that would be my long-winded answer of how you know through 2 big studies, the reference database study and the repeatability and reproducibility study.
Excellent. So yeah, I don't think anybody from Visionics is going to come up with anything better than that. That was fantastic. So I had no idea that you were actually involved with deriving that data. That's great.
It made you be really good at scan acquisition. You can imagine, Adam, I'm scanning this 83-year-old with wet AMD that can't fixate because we got to scan a certain number of wet AMD patients. She's 83, doesn't dilate well, and most 83-year-olds have floaters, and we're trying to scan through all that so we can get good scans to show it's reproducible and repeatable. Woo! We got good at scanning.
Holy smoke. Okay, so we have time for one more question here because I think we're just about at the top of the hour. And again, this is another practice management question. You may or may not have any insight into this in terms of the actual cost of implementation of the device.
The cost of the device?
Yep, and implementing it in practice. So essentially, I guess you have to obviously buy the device, but then how does it actually, actually getting the staff up and going and getting them trained on it as well? I think, soup to nuts, what does that process actually look like?
So I'm going to encourage you guys to reach out to the Visionics folks. They will take good care of you. I'm in such a unique setting at an optometry school. We don't have technicians. Our technicians are our students and residents. And our ROI is very different than your ROI. So, we have these devices and we purchase them for learning for our students and training our students and residents. So I would encourage you to get into contact with the Visionics folks, and they will take good care of you of how to, what the cost of the device is. I'm not even going to guess on, I don't want to misquote it. Cost of the device, talk with them on that, and then getting your staff trained. They will take care of all of that for you, of getting your staff trained. How do you scan patients? How do your technicians do that? So they'll be a tremendous resource for you.
Right, and in fact, when we've had private practitioners come and talk about the Solix before, they've all told me, I think to a person, that they don't ever really do the scans themselves. So that they would not be the person to ask, like, how to, hit the buttons and stuff. They literally don't know because Visionics trained up the staff, so they actually just, focus on interpretation and let their staff actually do the acquisition.
Yep.
Great. All right. Well, I think we are just 1 minute over. So Nate, thanks again for doing this tonight. I think we all learned a lot, and thanks everyone for showing up tonight. If you have any more questions, an archive of this webinar will be available on ODwire probably within the next 48 hours. We'll have it up there. And if you have any further questions, just feel free to answer questions in the discussion thread with the archive, and I'll make sure to pass them on to Nate, and we can keep the conversation going. So Nate, again, thank you so much for doing this tonight.
Thanks, everybody. Appreciate it, Adam. You guys have a great evening.
Have a good night.